Well, welcome everyone, and thanks for having me. This first slide is just some information about me. I'm not going to go through it. If you are having trouble sleeping tonight, you can read the slide. That should do the trick. Suffice to say that I meet the definition of an expert, which is a stranger from out of town with a PowerPoint presentation. So let's get on with today's objectives. We're going to talk a bit about the chronic care model and why it's an effective framework for improving quality care, and especially with diabetes care, and understanding the 6 core elements of the chronic care model and how it fits with the patient-centered medical home. I'll talk a bit about the past, about the chronic care model and its link to the patient-centered medical home, and then have a best practice that we can show you that it excelled using the chronic care model and became patient or NCQA accredited as a level 3 patient-centered medical home. I think that it's not lost on you the amount of people that are suffering from chronic illness. You see them every day in your practice. There are 117 million Americans suffering from chronic conditions, and 1 in 4 of those have 2 or more. And we know it's due in part to a lack of exercise, poor nutrition, tobacco use, poor lifestyle, and the costs are absolutely staggering. The one thing that you may not know is that many patients receive very little assistance in self-managing their health. And this is one big component of the work that we did when we created the chronic care model. We clearly have a lot of avoidable hospitals and ER visits and unnecessary deaths every year. And people are beginning to recognize the defects in care and expecting more from the healthcare system. I won't even get into the insurance issue. I was just saying to Grace that I'm a dual citizen of Canada and the US. And we have a single payer system up here, as you know, which is great from an administrative standpoint. It reduces the need to deal with all of the various insurances and dealing with uninsured people and that sort of thing. But it comes with its same quality problems because it's still based on the old model of care. And that old model of care is one that has really been disease focused. That is, we have built our system, it comes out of the First and Second World Wars, where the orientation was to rescue the soldier, repair the soldier, return the soldier to battle. And so what we have is a very good system of acute disease care, things that come on abruptly, their cause is usually single, the treatment is clear, cure is possible, and you know what to do. So we're talking about infections, injuries, those sorts of things. And the current system does a great job of handling all of that. But when it comes to chronic disease, typically these diseases come on gradually. There's no clear way to detect them. Treatments are usually very complex. No cure is possible. And there's often a lot of uncertainty in how you manage patients' care. So that's a very different type of system that we need to build to manage that kind of acute problem. And of course, as our population ages, this problem is becoming staggeringly difficult for primary care to manage. And the other important part is the professional's knowledge needs to be paired with the patient's knowledge of what it means to live with a chronic illness so that you two work together as a team. So we have to move from this acute disease system to this chronic illness system and build that part of the system. And that was the impetus for us creating the chronic care model back in the early 90s. We had a grant from the Robert Wood Johnson Foundation to review the literature and synthesize what was useful in terms of good chronic illness care. So the model itself isn't an invention. It's not something we made up. It really is just a synthesis of what works in terms of a synthesis of the literature of what works in good chronic illness care. We took the model on the road for the next 5 years, again with a grant from the Robert Wood Johnson Foundation to test it, to see if it was effective in transforming primary care into a better chronic illness care medical home. But what happened during the course of that research study was the model took off on its own. So HRSA actually was the first to pick it up in the United States and started working with federally qualified health centers to implement it in the late 1990s and the early 2000s. Veterans Affairs picked it up next, and the Veterans Administration started using it. It spread up here to Canada. It made us a little bit nervous as researchers, because all of a sudden here was this model spreading when we didn't know if it was effective or not. But suffice to say that at the end of 5 years, we found that it was very effective in transforming healthcare, and it became the basis for NCQA's patient medical home. And I'll talk a bit more about that. So what we really want to move from is today's care, which is your patients make an appointment to see you. The care is determined by whatever problem they show up with. The care can vary based on the scheduled time that you have and the memory or skill that you have of the patient. The patients are responsible for coordinating their own care, and the clinical operations of the center are meeting your needs, the physician and the practice team's needs, which is fine, but it also needs to meet the patient's needs. So when we move to chronic care model and PCMH care, we see the patients that are registered to our medical home. We know who they are. They aren't moving around to various parts of the system, so we can't track their care. The care is determined by a proactive plan to meet their health needs with or without visits. Care is standardized across based on evidence-based guidelines, and you measure the quality to make sure that you're constantly improving your system to better meet the patient's needs in a prepared, proactive way rather than just reacting to what comes in the front door. And you work as an interdisciplinary team that everyone is working to the top of their licenses to serve patients' needs. So that's what we're trying to get to. The trouble is it's very frustrating. How do you start? What do you know? Simply knowing what to do doesn't necessarily mean that the system's going to change. As we know, knowledge is necessary, but it's not sufficient to produce practice change or behavior change in people. So practice transformation really requires a commitment to system redesign from the very top of the organization right down to the frontline providers, including the patient and family. So it can feel very frustrating at first, but we have developed a process that is useful in transforming healthcare, and that's part of what I'm going to talk about today. So here you see a picture of the chronic care model and the 6 core elements that are in it. There's the way the healthcare system is organized. We have to deliver self-management support. We've got to redesign the delivery system, make better use of decision support, use clinical information systems to manage the population, and all of that health system, that improved health system, resides in a larger community that has resources and policies to support the work that you're doing, because a health system cannot do everything for the patient. As you know, and especially in Wyoming, social determinants of health are a huge factor for many of your patients, and those resources can be found in the community. They can't be expected to be inside the health system. Once you create this health system that does a better job of chronic illness care, you get a more productive interaction between patients. Patients are activated to take charge of their care, and you're a more prepared, proactive team that is looking forward as into the future for improving patient care. We know that when systems do changes along in these 6 elements, that there is improved outcomes in chronic disease, and we had a large-scale evaluation back in the 90s of our implementation of this work. Interesting to note for your folks' interest, the disease that we used when we took the model on the road to start testing it in systems across the US, the diseases that we focused on were diabetes, heart failure, and asthma. So we'll be talking a lot about diabetes today, because I understand from what Grace has told me that this is really an area of concern for providers in Wyoming. So the model is emphasizing that you become a proactive team, as I said before, that you identify patient populations and track outcome data, You deliver some level of self-management support at every encounter, and I'll talk a bit more about each of these. You conduct planned visits rather than reactive visits. Patient shows up at the door, or you open the exam room door and you go, oh my goodness, Mrs. C is in there who has multiple problems. This is not going to be a 5-minute visit or a 10-minute visit. It's going to be a 1-hour visit. So you want to be expecting Mrs. C to come in, not have her surprise you. Deliver care and case management to high risk and complex patients, and make sure care is coordinated through agreements with consultants and other community providers that your patients are seeing. And then develop efficient referral processes to community resources that help patients better self-manage. Now, Grace has informed me that resources are fairly slim in Wyoming, but there are ways that you could capitalize on the resources that you do have. So the chronic care model identifies those essential elements of the healthcare system that encourage high quality chronic disease care. That's what we're shooting for. I want to talk a bit about each of the 6 components so that you get a better sense of what's involved. And when we talk about the healthcare organization, you have to be in an organization that has accountable leadership that is committed to promoting improved care. What we've learned over the years of implementing system change is that if a practice does it on its own and the organization doesn't have leadership that sees the importance of what they're doing, they tend to be an island of improvement. That is, they operate on their own and they're not supported by the larger system. So leadership is absolutely critical. Good chronic disease management should be built into the business plan of the organization. System redesign that produces outcomes along the lines of the chronic care model and PCMH have to be part of the leadership approach. And more importantly, or not more importantly, but just as importantly, develop an infrastructure to sustain those system transformation over time. One of the biggest enemies of quality improvement is people leaving a practice or leadership leaving, and all that knowledge and information leaves with those people. And the people that are brought in to fill those positions bring their own level of care or bring the old way of doing business. So having a clear sustainability plan of how you're going to maintain your improvements is absolutely critical. So that's the first part. That's the top part of the organization in the chronic care model and how it needs to be organized. Self-management support, this is how do we help patients actually do self-care? And most organizations really struggle with this piece because it's not necessarily part of clinical care, but it is an adjunct to clinical care that absolutely needs to happen. What we know is we can show patients their treatment plans, we can explain their medications to them, but if they aren't able to self-manage their health, they're going to keep bouncing in and out of the system. So you want to make sure that you have someone in the practice that is trained in effective self-management support or someone linked to the community. You continually emphasize the patient's central role in their care, and you try to deliver some level of self-management support to those people that need it in the practice. And we could go into a long discussion about who gets self-management support and who doesn't, but that's for another time. I gave you an example of a very simple algorithm for helping patients set self-identified goals, behavioral goals, and action plans. This is part of a group that I'm currently working with, a small nonprofit that is registered in Washington State, and we've developed this concept of brief action planning. So again, you can go to the website and read more about that. But having simple tools to help patients set goals and action plans to change their behavior is a great way to deliver self-management support to them. I just wanted to include this slide. It's a little old, but it's a very effective slide. This was a meta-analysis done by Norris et al. Around self-management education and its impact on hemoglobin A1Cs for patients with diabetes. It looked at 31 randomized controlled trials, and what they noticed was that in each of the trials, there was an immediate impact on hemoglobin A1Cs. That is, it dropped A1Cs by 0.7 of 1%. So it's a big deal in terms of their impact. But you'll notice that 1 to 3 months and greater than 4 months later, after the intervention stopped, the reduction in A1Cs climbed back up again. So while there was still a reduction of 0.2 of 1%, we had lost approximately 0.6 of 1%, and that was because self-management activities in the practices stopped when the project stopped. So the takeaway from this slide is self-management isn't something that just gets done once or twice with a patient and that's fine. It's part of clinical care. In the same way that you put together a clinical management and medication management and treatment plan, patients need to have self-management plans in order to better manage their health. The third component of the model is delivery system design. So we have to build teams that focus on a continuing healing relationship with patients. Patients that that know their practice, know their providers, and have a relationship with them have better outcomes overall, versus patients that don't know their practice and the practice doesn't know them. We have to make sure that the roles in chronic disease care are clearly defined and distributed across the team members. And so that it's not just the physician or the nurse practitioner or the PA that's doing all of the work. It's got to go across everyone that's available in the practice. Now, each team differs in size, but clearly you need to sit down and look at what people can do and make sure they're working to the top of their license. Use planned interactions, and when I say that, plan visits with your patients. Don't wait for them to show up with exacerbations of their chronic illness care. Don't wait for their A1Cs to get out of control or their cholesterols or their blood pressures. Plan regular interactions with them that are more than just a check back. What you want to do is find out what the patient's issues are for that visit and address those, as well as addressing the clinical care that they need. Intensify treatment if goals aren't reached, so using stepped care or care management. Ensure regular follow-up. So an important thing to remember is that patients forget 50% of what they heard in a typical primary care visit. And so follow up to make sure that they understood their new medication plan or new meds is absolutely critical, because if you don't follow up shortly after a visit and they didn't understand their medications, and they're either going to be taking them the wrong way or not taking them at all, and you won't know until the next check back visit with them. And then clearly give care that patients understand and fits their cultures. One of the biggest struggles that we're actually having here in Canada, and especially in Toronto, which is where I'm located now, is we have 142 different languages that are spoken in Toronto. And so we have to make sure that patients understand what they're hearing, and we have a lot of different cultures, and we have to make sure that we honor those cultures and don't do things that violate cultural norms for these folks. That doesn't mean that you have to be culturally competent in all the different either immigrant populations or indigenous populations that you have in the state. But it does mean that when you're sitting across from someone different from you, you simply ask the question, we're different, how are we different? And have that conversation with them about what they need in terms of their care and how it fits their culture. I talked a bit about planned care already, so just making sure that you do planned visits and everyone on the team is prepared for those visits. The labs are in place, the patient knows why they're coming, the team knows why they're coming. Something that a number of teams developed over the years was this notion of huddling. So sometimes first thing in the morning, huddling and looking at the roster of people that are coming in for the day, and prepare for those patients that you know are going to be complex or have high social, psychological needs or complex care needs. And just that 5 to 10 minute huddle helps the practice feel much more organized for the day, and things are less chaotic, and there are less surprises when you open the exam room door, because you know who's going to be behind that door. Still under delivery system design is care management. We have a lot of patients that have very different needs. So if we look at patients with diabetes, clearly patients with A1Cs less than 7 their cholesterols are good, their blood pressures are good, are managing their care well, and you're managing with them well. So these folks don't need the same kind of check-back visit or follow-up visit that someone with an A1C greater than 9 needs. So organize your care appropriately. Take a look at your population, and I'm going to talk about information systems in a minute, but you can organize your population based on A1Cs or the ABCs of diabetes and sort them into low or good clinical control, moderate clinical control, and high need for clinical control. So clearly, for those folks that are A1Cs are greater than 9 and their cholesterols and blood pressures are out of whack, they're going to need intensive self-management support, close monitoring on their medications and medication adherence. They're probably transitioning around in the system from the hospital to back to you, maybe to other specialists. So you've got to make sure that the transitions are safe and that there's good follow-up after a transition. We know basically that if a patient comes out of the hospital for whatever reason and primary care follows up within 7 days, it reduces ER visits or readmissions by up to 50%. So these complex patients need coordination, not only navigation through the system, but complex clinical management as well. And they need a clear partnership with the care provider, whoever is delivering that care management to them. Decision support, the fourth component. Here we're really talking about embedding evidence-based practice into care. The American Diabetes Association guidelines of care are one example of guidelines that you would be using. The other piece is ensuring that you have very clean handoffs to specialty care. So we don't want patients going out to specialty care and specialty care hanging on to them. Once specialty care gets them under control, they need to be brought back to primary care with clear referral guidelines and your questions being answered by the specialist in terms of what they did to get the patient back in control. And here with the referrals, you want to leverage your electronic medical records to the highest functionality so that when you refer a patient electronically, it gets there, it's not lost on a fax machine, and the specialist knows exactly why the patient's coming and what your clinical questions are. Here's an example of a diabetes protocol that Grace found for me out of Diabetes Care magazine. These are the kinds of things that you want to build around the patient and decide where do you need the specialist care, where do you need community resources. But essentially, it's a nice way of looking at how do you control a patient with diabetes and make sure that their glycemic control as well as their lipids and blood pressure are under control. So these are the kind of decision support tools that you want to make sure are embedded in the practice. Clinical information systems, the fifth component of this. You need to be able to use your EMR as a registry. Can you identify all of your patients with type 2 diabetes and a very simple way to do it is to go into your registry and look for any patient that is coded with a 250.XX in the last year. If they have 2 codes that way, then you can be I believe the specificity is 98% sure that they have diabetes. You don't want to just use one because it might have been a rule-out visit. Once you identify your population of patients, and I think you'll be surprised at how many are there, you can use that information to begin pushing reminders to them and recalling them for services that they haven't received. Quite often, patients with diabetes don't have the things that are missed are annual foot exams, retinal screening, renal screens, depression screening is an important one too. About 30% of the population will have at least moderate to severe depression. And then you can also risk stratify them for that care coordination piece that I talked about before. So what's the level of their control across the ABCs? What is their competence to manage their health? We know that if you have information on those 2 pieces, their clinical control, and you ask a simple question, how confident are you that you can manage your health the next 2 months or 2 weeks, 2 months, well, 1 month, whatever it might be. Those two questions will help you stratify the population in terms of complexity. And again, I'll provide Grace with a very simple tool for measuring confidence and how to link that with clinical control. So your EMR is now your population management tool. Community resources, how do we address those lifestyle issues and the social determinants of health? I know that you're not community resource rich in Wyoming, but one thing that we do know when we work with practices is they often don't know what all the resources are that are available in their community. So it's identifying those resources is important. I don't know, Grace, if there's something like 311 or 211 in the Wyoming area, but if you have something like that, make use of that. Discuss your patient's needs. It's very important to do an assessment of what their social determinants are, because as you know, you can do all the excellent diabetes management with the patient, but if they can't afford to feed themselves, then that's going to be taking priority, not the diabetes treatment plan or the medications or any of that. If they're suffering from depression, they're not going to be able to care for themselves, so the depression needs to be addressed first. If they can't afford heat in the winter, all these things are absolutely critical and impact patients' ability to take care of themselves. So assessing what their social determinants are is extremely important, and getting them to the community services that they need to solve those problems removes those barriers for you in terms of treating them from a clinical perspective. So those are all the components of the chronic care model, and it's a pretty whirlwind tour, but I also want to point out how it fits with the patient-centered medical home. I was saying to Grace the other day that the history of the development of the chronic care model to the patient-centered medical home was a fairly natural one, in that NCQA approached us and said, we think that we need to accredit people based on the components of the chronic care model, as well as other components. And so we worked closely with NCQA over the years to develop the patient-centered medical home criteria. But there are some things that were not in the chronic care model, and they were things like patient access, advanced access. We did include continuity of care. We didn't include things like payment reform. We didn't look at electronic e-prescribing or e-labs. Those were actually prior to the chronic care, or they came after the chronic care model. So when you look at the patient-centered medical home, it's a more comprehensive model of everything that needs to be done. But all of the components that are in the chronic care model are in the patient-centered medical home. So they aren't, you're not duplicating effort here, you're not having to do two different models. They actually fit very well together. Both of them emphasize the importance of supporting the patient in their role as a decision maker. They both promote the importance of self-management support, which, by the way, is now becoming, it's very clear that patients that have high confidence in terms of taking care of their health have better outcomes. And so self-management support, the purpose of self-management support is to build patient self-efficacy so that they can take better care of themselves and reduce the burden on you. Both models detail the need for effective use of clinical information technology, community resources, coordinated care. CCA, the chronic care model, redesigns care around that planned visit. The medical home is now picking that up also. But the medical home, which is very important, redefines primary care as the home that is responsible for all of the patient's care, for coordinating everything that goes on with them. So both models contain useful change information and practice transformation information, and they are very complementary, and they do duplicate each other quite a bit. So not to worry that you're dealing with two different models. What have we learned over the years of helping practices transform care? The first thing is leadership. Can't say it enough. If the organization doesn't have the will to change, and that will needs to come from the leadership, it won't happen. Measurement is a burden. In order to do quality improvement, you have to have measures to see if what you're doing is resulting in improvement. And it can be difficult to do measurement, although there are very simple ways to do it that we've worked with teams in terms of what they can pull from their electronic medical record and keep measurement relatively simple. Diversity across and within regions. So I'm sure as we look across the state of Wyoming, patients in more urban centers are going to have access to resources where those in extremely rural areas, and actually I believe Wyoming is considered a frontier state where some patients are more than 120 miles from the closest hospital. So there's going to be real differences in how you serve those populations, and that can be difficult when you're transforming care. The crush of competing priorities, what I mean by that is your leadership has to have the will to change, but they also could easily get distracted by other priorities. So keeping focused on what it is you want to do around improved chronic illness care is absolutely critical. Teams need technical assistance. So what we did at the McCall Institute for years was provide technical assistance for people to implement the chronic care model while we were funded for Robert Wood Johnson. You have technical assistance in terms of the Primary Care Association, in terms of your QIO, which I forgot the name of, but Grace will tell you. These are organizations that can help you with transformation. There's also ways of doing it across the whole state in terms of learning collaboratives from the Institute of Healthcare Improvement, which we've partnered with for years. There's a real need for peer-to-peer learning. It's one thing for an expert to come into your practice and tell you what to do. It's another thing to work with one of your peers who's gone through the transformation process and can show you what to do. And that peer-to-peer learning has much more impact than a sort of sage on the stage model. And then the other thing that we've noticed is the incredible creativity in the teams that we've worked. So many problems that seem intractable, teams figure out a way to solve them. And so for all of you on the phone, you're probably at a number of different federally qualified health centers, start talking to each other. Talk to each other about what issues that you might have at your FQHC and see if others have dealt with that issue and solved it. And then finally, sustainability. Many of the improvement efforts that go on in primary care transformation are funded by one-time funding sources. And so they're treated somewhat like a project. And at the end of the project, there's no sustainability plan. And what happens is you go back to the old way of doing things. So making sure that any improvements you do are built into the system, they're written into your policies and procedures. If someone new comes into the practice, they're trained on the new way of doing care, so they don't do the old way of doing care at the previous organization they were at. So that sustainability piece is absolutely critical. So during the last 20, 30 years, what we've used is this recipe for improving outcome. And it starts, as I said before, with leadership, evidence-based, number two, evidence-based clinical guidelines for care. So you make sure that you know exactly what all the care guidelines are for diabetes. A system change strategy, like the chronic care model. So inside that, it has all those components that we talked about of how to go about changing the system. The patient-centered medical home is another one. And then number three is a QI strategy. The model for improvement is one that I've used for years. It's a very simple model that helps you set up projects with clear measurement and teaches you a way to test ideas on a very rapid scale so that you learn what works and what doesn't work when you're trying to implement something, rather than jumping to implementation and finding out all the mistakes then. I could do a whole talk on the model for improvement, but it is a terrific tool. Google it and you'll be able to see. Actually, what I'll do is I'll send Grace, I've got a good 2-pager that you can share with the teams that explains the model for improvement. And then some sort of learning strategy, whether it's a series of webinars, but whatever the learning strategy is, it needs to be action oriented. That is, you need to have a set of tasks that you've got to do to complete rather than it just being a didactic talk. I mean, what I'm doing right now is helpful, but it's not sufficient to result in practice change. You've got to actually be doing the work and be guided in terms of what work you need to do. So an action-oriented learning strategy is absolutely critical. I mentioned earlier that we talk about a high-performing practice. Maple City Healthcare Center is a center in rural Indiana that serves about 3,000 patients. It became part of a group of high-performing organizations, teams that were looked at by another Robert Wood Johnson program called Improving Primary Care. Maple City had worked with us in Indiana. I'd worked with them through the Indiana State Health Department, and they did a very good job of becoming a patient-centered medical home at level 3. And so when the Improving Primary Care Project was looking for high-performing exemplar practices, this was one of the federally qualified health centers that was chosen. Since we evaluated them for the Improving Primary Care Project, they've also implemented a number of community-based programs that have helped support the clinical care that they deliver, such as elementary school scholarships. They have another program called Our Futures Together. You can read all about these on the Improving Primary Care website. Centering pregnancy and doula services, looking at money programs to make sure people have enough money to buy their medications, a community garden, and then a board of directors that was actually made up of community leaders rather than medical professionals. So it's a good team to look at in terms of how they've moved forward. I was telling Grace that they had a number of people leave the practice, and the sustainability has been an issue for them. I'm still working with them in Indiana, but with the leadership leaving and some of the clinicians leaving, it's been hard to sustain the great work that they've been doing. So that sustainability plan is absolutely critical. So overall recommendations to improve diabetes in population health: make sure that treatment decisions are timely and rely on those evidence-based guidelines, and that you work collaboratively with patients. Remember that your clinical goals are important, but they may not be the goals for the patient. The patient's goal may be simply to get back to the way life used to be. When you look at the roles and when you ask patients what they want once they've been diagnosed with diabetes, the first thing they want is for things to go back to the way they used to be. So recognize that controlling their A1Cs may not be part of their, may not be in their I'm sorry, I've lost the word, but it may not be on their radar. Controlling their cholesterol may not be on their radar. These are important things that need to happen, but for them, getting back to a normal life might be critical. So you have to integrate your professional knowledge with their life. Align your diabetes management program along those elements inside the chronic care model to make those interactions more productive. And you want to be prepared for those patients when they're coming in. And the care system should facilitate team-based care. Make sure you have patient registries. Can you pull those patients from your EMR and the appropriate decision tools, and involve the community to the best of your ability. This comes from the standards of medical care in diabetes, and Grace has the article that she will send to you if she hasn't already. So there are lots of resources to help you get started with this. These are just a handful of them. I like the ARC Primary Care Medical Home Resource Center. It's organized nicely. The tools are easy to deal with. So you can go there and look at some of the tools. One of the things you probably want to do very quickly is sort of assess where are the gaps in terms of your ability to be a patient-centered medical home. The improvingprimarycare.org has a great assessment on the front end of it that allows you to assess your practice and see where you could start doing quality improvement. So I recommend you take that assessment. It also has the 33 exemplar practices, many of which are federally qualified health centers, that you could take a look at, as well as all sorts of tools that you can download that will help with PCMH status. And then there is the NCQA site, which has clearly all the standards for becoming a patient-centered medical home. And you can take a look at that website also. This is the original chronic care model site that we created back in the 90s. It gives you more information about the chronic care model. It is a bit dated, but there is useful information there around each of the elements of the model. And it also has our evaluation of the 5-year evaluation that we did. And I noticed there, I haven't looked at it in a while, I noticed that they've linked it to the patient-centered medical home. So those are all resources that will help you get started. That was a real whirlwind tour, and I know it was a lot of information, but what I really encourage you to do is I'm happy to answer any questions. Please feel free to email me or call or ask me to call you. I'm happy to help in any way, and I just hope that you do well on your practice transformation journey. And I'll open it up to questions or comments, Grace.
Thank you. Does anyone have any questions or comments about the chronic care model, of how you've used it and how, you know, it has its failure points, or what, you know, tell us about it. We kind of want to learn from people's mistakes or from their successes. So please unmute yourself and let us know what you think about this. You guys, I know you're there. Well, one of the things. Go ahead.
I have a question for the group.
Okay.
In 2000 and 2001, HRSA sponsored the Health Disparities Collaboratives, which was a set of learning collaboratives across the U.S. Where all of the federally qualified health centers had to participate in at least one learning collaborative. Is there anybody on the phone that remembers participating in that collaborative?
No, I don't think we have. Hello?
I'm just looking at the chat. Okay, no response. So the reason I asked that question is, again, this goes back to the sustainability issue. So many of the, well, all 850 at that time, 850 federally qualified health centers went through a learning collaborative to learn the chronic care model. What's happened in the last 20 years is that there's tons of practice turnover. So it wasn't built right into the system. And what happened is that many of them have gone back to the way of doing things. So I think the Health Disparities Collaborative website is still up, so it's something that you could possibly look at. The other thing I want to say too is that one of the troubles with sort of presenting the model all at once is I hear from many practices, they say, oh my God, where do I start? And the answer to that is start wherever you feel you want to start. There's no particular sequence of how to implement the chronic care model or the patient-centered medical home. What I typically advise practices is start where you're feeling the most pain. Many practices feel like access is their biggest issue, so I start there. Many feel that they don't have a good handle on who their population is. Okay, we'll start thinking about registries. It's the same kind of advice we give our patients. If you have a brand new diagnosis of diabetes, there's an awful lot of things you have to do. And as you know, patients get completely overwhelmed. So from a self-management standpoint, we typically say to the patient, what is it you want to work on first? And if they identify something, then they are much more likely to have success, because that's the issue that's most important for them. So I use the same kind of approach when talking to practices about how do you transform care. There's so much to do. Start where you feel you want to start, because that's where you're going to have the most success. And what you want to do is build your confidence that you can actually change the system that you're working in, because once you get that confidence, then change accelerates very quickly.
Mike, we had a here on the chat that there was somebody who worked with a collaborative, and it was good but heavy and busy work.
It is, yeah. Well, I'm delighted that you did work in that collaborative. You're the first person I found in a long time. Can you say a bit more about heavy and busy work? Because change is tough. You mind commenting some more, Ben?
You can unmute yourself.
No, we might have lost him.
Okay. Well, can you see the screen now on the diabetes standards?
I can.
Okay, perfect. Well, that's the whole, I was reading this and I came across this chronic care model, and it was extremely emphasized that it was very good at improving diabetes care in patients. So I'm going to send this to you, and that's one of the whole reasons I Googled and I found Mike and I talked to Mike and I told him, well, we have a great need in Wyoming to improve diabetes health. And so during the second page here, you'll see also where it also highlights those six core elements and the importance of them to improve the care of the patients. So if you have any questions even after this on how to start, where to start, please either call Mike or I, and we will help you because it is proven that it works. And I know that some of you already are doing PCMH recognition process. If you're doing that, that's great. If you're not, start with the chronic care model because it overlaps and it's the same things. And at the end, what we want to do is have good outcomes in patient population.
I'm looking at the conversation between Jennifer and Stavana about walk-in clinics.
Okay.
It's great that you've created this new clinic, and I assume the clinic on Tuesdays is you schedule appointments for people with chronic illness so that you know that they're coming in and can address their chronic disease issues. This is one of the biggest struggles that many clinics have, certainly walk-in clinics, but it's also one of the struggles that people have with same-day access. So if you're moving towards same-day access, remember that people with chronic illness need those planned visits. And it's best to set up your schedule so that part of your day is available for same-day access, but also part of it is planned visits with people with chronic illness so that they know when they're coming. If you have same-day access for your whole day, then people with chronic illness have to call and make an appointment, and that typically doesn't happen, so they miss a lot of their visits.
Okay.
Other questions or concerns about this? As I said, just start. That's really the key. Don't try and figure it all out ahead of time. Just start where you're ready to start. Deal with the pain points in your practice and address them one piece at a time. We typically see that it takes a number of years for practices to completely transform over to a medical home. 2 or 3 years of hard work, as Ben said. It's heavy lifting. He said busy work, and I don't want, if you're feeling that the work that you're doing is busy work, that it's probably not work that's making a difference in your practice. So you have to stay focused on what it is that's really going to make a difference in terms of your clinical outcomes, your staff satisfaction, and depending on your organization, your return on investment.
Good. Thank you, Mike. Is there any other comments or questions? Would you guys be interested in a second version of this or anything that will help you either breaking these down in the 6 components and addressing them individually in different webinars? I just need to know how to help you so I can help you. Anything you guys need, we're always here.
And to sort of jump on to Grace's questions, I would be happy to do another webinar on self-management support, because I think that is really a big leverage point for your working with your patients, and especially given the geographical range that you have, getting patients self-managing better would be a high leverage activity for you.
Are you guys interested? Send me an email, message.
Yeah, they don't have to say right now.
Yes, very informative. Thank you. Oh yeah, look at that. Thank you, Jennifer. So yeah, okay, so we will get together, Mike and I, and we will put together something for you in regards to self-management support, and maybe even focusing it also on this patient population that is homeless, because that is one of our challenges, or patients that we can't get a hold of, or bringing them back in. Mike, what do you think? Because I think that's our toughest population.
Yeah, absolutely. Yeah, we can talk about how to address that.
Okay, perfect. Okay, perfect. Thank you. All right, well, our time is up. I appreciate your patience with us. Sorry we had a rough start at the beginning and a little bit chaotic, but I appreciate you sticking through and staying for the entire presentation, and we will continue this to the next step. Thank you, everyone.
Thanks, everyone.